Efficacy of Tadalafil in secondary Raynaud's phenomenon resistant to vasodilator therapy, a double-blind randomized crossover trial. The presenting author is Dr. Shenoy, and this is from the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, India. Dr. Shenoy.
Dr. Fox, Dr. Crawford, ladies and gentlemen. It's a pleasure to present here the first randomized control trial of Tadalafil in secondary Raynaud's phenomenon on behalf of my co-authors. We have no financial disclosures to make. Introducing the topic, Raynaud's phenomenon is an exaggerated vasoconstriction in response to cold. It can be primary when not associated with an underlying disease, or secondary when the evaluation reveals an underlying illness. Secondary Raynaud's, especially when associated with scleroderma, is more severe than the primary variety. It causes more intense vasoconstriction, leading on to ischemia, resulting in ulcers or even gangrene. Current therapy of secondary Raynaud's is suboptimal and challenging to the clinician, as there are limited number of drugs available and the available drugs are not panacea. Phosphodiesterase 5 inhibitors like sildenafil act by dilating the blood vessels. These groups of drugs have been widely used in the treatment of erectile dysfunction. Recent reports suggest that this drug may be efficacious in the management of Raynaud's phenomenon. Sildenafil with a short T-half is ideally suited for the management of erectile dysfunction. But to manage a chronic condition like Raynaud's, we need a drug which acts for a long time. Tadalafil with a half-life of 17 hours is better suited for this. Aim of the present study was to assess the efficacy and safety of Tadalafil in secondary Raynaud's phenomenon. We included patients of systemic sclerosis or mixed connective tissue disease, having Raynaud's phenomenon with more than 4 attacks per week despite on other vasodilators. Patients of severe lung or renal disease, or those patients currently on medications which are contraindicated with Tadalafil like nitrates or alpha blockers were excluded. Those patients who had coronary artery heart disease or were on phosphodiesterase inhibitors already were also excluded. Study was conducted in the last winter from first week of December 2007 to second week of March 2008. Severity of Raynaud's at baseline was assessed during a run-in period of 2 weeks before the commencement of the study. After this, patients were randomized into 2 groups. First group received Tadalafil 20 mg on alternate day for 6 weeks, and the second group received a matching placebo. After a washout period of 1 week, patients were crossed over to the other arm. Clinic visits were planned at 0, 6 and 13 weeks. I would like to emphasize that existing therapy, including the vasodilators, were continued unaltered throughout the study, and the Tadalafil was an add-on therapy. Our primary outcome measure was severity of Raynaud's. This was assessed by number of Raynaud's attacks, duration of Raynaud's attacks, as well as Raynaud's clinical score, recorded by the patient on a daily basis in Raynaud's diary. Secondary outcome measures were change in ulcers, improvement in functional outcome, as well as improvement in endothelial function as assessed by flow-mediated dilatation. Functional outcome was assessed by scleroderma visual log scale based on the effect of Raynaud's, ischemic ulcers, pulmonary symptoms, as well as gastrointestinal symptoms on patients' day-to-day activity. Of the 27 randomized patients, 24 completed the treatment successfully. 2 patients withdrew consent without taking the drug, and 1 withdrew after taking a single dose because of a side effect. These 3 patients are not included in the analysis. Majority of our patients had diffuse scleroderma and were on a combination of calcium channel blockers and angiotensin receptor blockers. Despite being on a combination, they had severe Raynaud's with around 50 minutes of attacks per day, indicating a severe vasculopathy. This slide depicts mean daily frequency of Raynaud's attacks. Blue bar indicates the baseline, green indicates placebo, red indicates Tadalafil. There was a significant reduction in the frequency of Raynaud's attacks when the patients were on Tadalafil when compared to baseline and placebo. Similarly, as expected, there was decrease in the daily duration of Raynaud's attacks also. Raynaud's condition score, which is a measure of severity of Raynaud's assessed on a daily basis, also decreased significantly when the patients were on Tadalafil. Lower the Raynaud's condition score means less severe Raynaud's. Although the effect on ulcers was not our primary outcome, the results were promising. In the first group, there were 9 ulcers at baseline, all of which healed during Tadalafil treatment. And during the same period, no new ulcers appeared. So while crossing over to the other arm, this group of patients did not have any ulcer. But during placebo treatment, 8 new ulcers appeared. In the second group of patients, there were 13 ulcers at baseline, and 3 of them healed and 5 new ulcers appeared during placebo therapy. So while crossing over to the other arm, this patient had 15 ulcers. On Tadalafil treatment, all the 15 ulcers healed and only 1 new ulcer appeared. Summarizing, all the 24 ulcers healed during Tadalafil therapy compared to 3 out of 13 ulcers during placebo treatment. 13 ulcers appeared during placebo treatment compared to a single ulcer during Tadalafil arm. Coming to the functional outcome, limitation of activity due to Raynaud's as well as ulcers, as assessed by scleroderma visual analog scale, improved significantly when the patients were on Tadalafil. Patients also reported that the limitation of activity due to scleroderma as a whole also decreased significantly when patients were on Tadalafil. Patient as well as physician global assessment also improved significantly. Flow-mediated dilatation, a marker of endothelial function, improved significantly when the patients were on Tadalafil. This is really encouraging, as endothelial dysfunction is one of the key pathogenic factors in scleroderma. There were no major serious adverse effects reported during the study. Although not statistically significant, minor side effects like nasal stuffiness, rhinorrhea, heaviness of lids were more common when patients were on Tadalafil when compared to placebo. One patient withdrew from the study due to persistent non-painful erection which interfered with his daily activity. He wanted to continue the drug at a lower dosage because he had excellent relief from his Raynaud's. But as this was a violation of the protocol, this patient was excluded from the study and was not analyzed. Our data demonstrate that Tadalafil is effective in the treatment of Raynaud's secondary to systemic sclerosis. It decreases the severity of Raynaud's, it heals existing and prevents new ulcers, it improves functional outcome as well as endothelial function as evidenced by flow-mediated dilatation. Thus, Tadalafil is a promising agent in the management of most difficult patients of secondary Raynaud's who do not respond to conventional vasodilators. Thank you for attention.
Thank you very much for that outstanding presentation. We have questions over on the left, please.
Albert, Dartmouth. That was really interesting and very exciting for our patients with really severe Raynaud's. I assume because you didn't have any financial disclosures that this wasn't an industry-sponsored trial. And I was just wondering where you got the Tadalafil to do this study, because it's very expensive, and I've not been able to get it from my patients that have this problem.
Yeah. I am coming from India, so we have a lot of generic versions available there, which are not as expensive as the patented brands.
So I assume that, and I was just wondering if that was a manufacturer that was licensed by the patent holder, or was this essentially a black market drug?
Not centrally black market drug. It is licensed in India for use by DCGI. Our Indian Director Control of.
Thanks.
In the middle, in the back.
Jürgen Braun, Germany. I wonder whether you can comment on the dosage. I remember there was a trial with sildenafil with 2 times 50 milligram. Would that be equivalent to 20 milligram, or can you answer the question why you only tried 1 dose?
Yeah, that's an excellent question. This 20 milligram alternate day we chose based on some case reports which have shown response to this therapy. Secondly, there was a study 2 years back on 6 patients. They have used Tadalafil 10 milligram alternate day, and they could not show any improvement in peripheral blood flow. That's why we chose 20 milligram alternate day. The equivalence cannot be tested unless we prove it scientifically.
Yes, here.
Yeah, hi, Spira, New York. We know placebo effect can be strong in treating Raynaud's. How good was the blinding in the study in terms of the patients guessing whether they were on active drug or placebo?
Yeah, thank you. Patients blinding was perfect in the sense only most of the patients could not guess whether they were on drug or placebo. Coming to the placebo effect, although in the graphs where I have shown that there was no improvement with placebo, when we individually analyzed the patient, there were 25% of the patients who had shown more than 25% reduction in Raynaud's attacks. So there was a placebo response. 1/4 of the patient responded to just placebo. But the response in the drug group was much, much higher when compared to the placebo. That's why this statistics shows like this.
Yeah, and patients could not tell which they were on.
They could not tell. They could not tell.
In the middle, in the front, please.
Shenoy, congratulations. As sildenafil doesn't seem to work in ulcers, so the healing of ulcers suggests that actually it really worked. Did you have pulmonary function studies in these patients?
No, we did not have.
I'll take 2 more questions. One in the middle, in the back.
Weinberger, New Jersey. Did you have any patients who had complete resolution of Raynaud's rather than just a reduction in attacks?
Only single patient had complete resolution. Only single patient.
And then the last question over on the left in the back.
Goldman, Atlanta. I do this clinically, and insurance doesn't pay for this for your patients, of course, but I use pill cutters and am able to adjust the dose beginning with a 1/4 of a pill every few days or even less and going up. And I agree. I think it is a successful type of therapy in many patients.
Thank you. I'd like to thank everybody for your attendance at this initial plenary session, and thanks to all the presenters.